I will give now the summary of the session, what did we learn, and we have some key messages for you. So one is to act transsectorial to systematic threats. We find out if we really want to tackle a health burden of emerging and re-emerging infectious disease, we have to value diverse perspectives and local experiences. So the local people are the experts in the field. We should also take the lead to adaptable, broadly applicable solutions for pandemic preparedness, and this does not include only disease control, but also the outbreak prevention, which is quite often forgotten. If we talked a lot about mosquito-borne disease as one example in a climate-sensitive context, and here, of course, a lot of prevention has to be done. We should develop, sustain, and also the enhanced existing operational capacity in an innovative and integrative manner. This sounds quite generous, but it's really needed. We should enrich the European research with multi-sectoral collaborations, and I think that's also a major challenge because we have to break down silos in the funding landscape. We have to break down silos in the policies. There is really need for transsectoral support across topics like biodiversity, environment, climate, health, also the veterinary and food sciences, because the diseases that we are facing, they need really an integrated and multi-sectoral approach to tackle. I continue? Okay. Then a second key message. Let me see. Yep. There was a really nice citation which I just want to read out again. No one is safe until everyone is safe. It's a cliche because it's true. Was true for COVID. It's still true for climate-sensitive diseases like dengue, for zoonotic diseases like monkeypox, and for all emerging viruses. And I think it's a very strong statement, and I really would like you to think about that, how we can take action to make all of us safe. How we can do it? We should enable joint learning for local preparedness through transcontinental, equitable research partnerships rooted in mutual trusted relationships. We should also enable long-term sustained collaborations efforts to pursue long-term, to jointly identify priorities over peacetime and also over the poly crisis that we are facing, and also include flagships for agile response. Another recommendation is to further strengthen the growing capacity in the Global South through collaborative research and know-how. Technology sharing is very much needed, and we should think out of the box. So innovative thinking about intellectual property rights, for example, in a public health context. Then we talk about a funding model that fosters synergy across research, training, health technology assessment, emergency response, and international cooperation. And this will help us also to really tackle this or to manage these health threats. And the last slide that we would like to share with you now is about a commitment to end-to-end research to strengthen cross-regional resilience. And end-to-end research, it sounds very much like product development, marketing change, but we see it a bit broader. We really think about have a full research cycle from fundamental to applied research to operational research, implementation research, quality assurance, and then of course also research and policy health. And all this should be included all the way from local to regional to global. That's quite a task, but I think it's very much needed. And the policies I mentioned already, they should be coordinated and integrated. That means ministries, for example, have to work together to come up with a really multi-sectoral approach. Why we should do this, and here we had a very strong input from the Public Health Department at Institute of Tropical Medicine to foster local regional health innovation and achieve contextual relevant interventions, strengthening and innovating health product ecosystems. We will reach with this approach. We can promote continental self-reliance in health product supply chains and globally diversify quality-assured health product supply chains. So that's in a nutshell. We could talk longer, but unfortunately we're a bit limited. Thank you.
And now for the summary of the third parallel session which took place here, I would like to introduce Professor Van Damme, who is already here.
So thank you. Yes. And I will start first with something that was not discussed. But during COVID-19, I followed the newsletters of your local epidemiologist, Kathleen Italiana. And Kathleen Italiana last week was considered by Times Magazine as one of the 100 most influential persons of the year. And I think that says a lot. And what her lessons learned from COVID-19 were, is science is ever evolving, and I think that is very positive. It never stops, and that's what we also need to understand for the future. A healthy population is a healthy economy. Both are linked, and these interests are indeed not competing. In many countries and parts of the world, we saw that inequality is very apparent when the whole country is put under pressure, in particular during a crisis or during a pandemic. It's easy to criticize the past with the eyes of today. We have to be very careful. The art is to understand the past with the eyes of the past and the eyes of today. Public health works, but that makes it very invisible and not very apparent. And public health is a cycle of panic and neglect, and we all have seen that also in many social media messages in the last months and even the last year. And what I liked, Nina, in the introduction, I don't know, where is Nina? She disappeared. Oh, there, oh, all right. What I liked in your introduction of our workshop is that you used both words, preparedness and readiness. For me, it's really different, and readiness has a bit more emergency than preparedness, and I think we have to move in the direction of more readiness. So that's the first thing. We had several presentations. You can see them here, but I will go into detail so that you oh, something happened here with the slide, but doesn't matter. So this is about the first talk, and the first talk was to make clear that vaccine trials are something separate and something very specific as an entity in the large family of clinical trials. Because of the sites that participate in vaccine trials, because of the population that we address, and these populations are very often healthy people, and only in a second phase we will go to immunocompromised or to elderly people. And of course, you need to be connected with a lab that is specialized in immunology. And that is also very particular for vaccine trials. And it was made clear that we need to have a vaccine immunological lab network in Europe. That needs to be connected, of course, with the vaccine trial network. And we can take the example of Belgium, where within the European Plotkin Institute of Vaccinology, we have the University Libre de Bruxelles and the University of Antwerp, who are connected. The immunological department of the one university connected with the vaccination site of the other university, working together. And I've mentioned there indeed our Vaccinopolis at the University of Antwerp, where we can now do also human challenge trials, which need to be very well connected with the immunological lab, and I will just illustrate why. Network of a research lab in Europe, there is one, led by Kristen Drosten, And I think we have to think about, and that's maybe a call of action, to see whether that network can also work and function or liaise with a network of immunological lab. In that same talk, the emphasis was put, of course, on very important issues and very important topics that need to be taken into consideration when we talk about immunology, the vulnerable populations, the optimal use of vaccines, and that can, of course, be looked at in the interpandemic, in the peacetime period. Schedules, heterologous schedules, the dosage, the durability, the boostability, the way how we can evaluate new vaccines against new variants. Of course, also think about more efficient vaccines, more rapid development and assessment of those vaccines, and finally also move more in the direction of defined correlates of protection, which can be done during a peacetime period, and increasingly also look at prevention of transmission. So far, in fact, we have not looked at this transmission blocking potential of interventions, whether it is antivirals, whether it is monoclonal antibodies or vaccines. Increasingly, this becomes important, and we have seen that with COVID-19, and we have to take that also into consideration. Can we clearly document the mucosal immunity? Can we have a correlate of protection at the level of the mucosal immunity, and can we use that to define the blocking potential of transmission? We had also talk on antivirals, and I think there what we learned is we need to have several layers of protection, several layers of controlling an outbreak. Not only vaccines, we need to have the monoclonal antibodies, we need to have the antivirals. Antivirals indeed will be or are the first step in the control of an outbreak, or in particular in the control of a disease in a specific population. They have clearly also advantages, and all that work can also be done today, now. We don't have to wait for a pandemic to invest in this activity. And the virus bank that was created at the University of Leuven is indeed a tool for pandemic readiness. Modeling, and the title disappears, I don't know where is the title, but anyway, on the part of modeling, the aim of modeling is in fact to try to mimic the real world. And the main contribution of a model is really to understand the dynamics of an infectious disease. Models should provide evidence, but the advantage of models is that they also can look at a what-if scenario. What if we close schools? What if we vaccinate a certain age group? What is the consequence of that? This can be modeled, so that's quite interesting. There are, of course, challenges in those models. What we see in practice is the medical status of the subject. And that's where we have to start from, and that's where we have to connect with other elements, with other data. Very often there are missing data, in particular the behavioral data, but I come back to that. The access to data sources is not evident at all, and that needs to be improved. Incompleteness of data. Biases in, of course, setting up these models, and we have to recognize that, and we also have to communicate about the limitation of the models, which is, of course, not easy, particularly if you communicate to a large population, or when you talk about uncertainties of models. Models can assume incubation period, generation interval, but what is interesting is that the next generation of models will be able to look, let me see. Yeah, there it is, thank you. We'll be able to look at the role that children play in the dynamic of an infectious disease, the role that age-specific susceptibility plays in the dynamic of an infectious disease. So in order to be better prepared, it's important to collect the right data, also in peacetime, so also that can start today. Collect data on behavioral, behavioral characteristics of a population, of a certain age group. We should invest much more in sharing data, and of course in have EU modeling hubs and use artificial intelligence where applicable, where needed. The second part on modeling was more focusing on the pandemic intelligence. And the focus was really on digital epidemiology. Digital epidemiology, and I think what is interesting is that the forces of shaping variation in burden of disease and dynamics of burden of disease is social. It's not biological. So we need to understand that. So focus on human behavior is tremendously important, and in particular, adding those data into all those modeling exercises. Like how to control, or what is the impact of controlling measures? How well do populations, do individuals follow the recommendation on controlling measures? How does the population respond to that? So collecting non-traditional sources of data, like mobility data, data on sentiment, on economic, is equally important. And finally, integrate traditional and non-traditional data into those models, like data on school attendance, work attendance, avoiding crowded places. This is behavioral, and that tells a lot in terms of the dynamics of infectious diseases. And of course, participatory surveillance. So what do people think about risk? What is the risk perception in a population? What are the attitudes in a population? So also those data are tremendously important. We had to talk about the situation, or at least how Hungary tried to organize themselves to address the pandemic. And something is missing on this slide, but doesn't matter. In fact, we were told about the multidisciplinarity of a team and the importance of the multidisciplinarity of the team, representing, I think, more than 20 disciplines. And they created a national lab of health security in Hungary. But today, the challenges are the structural funding of that lab, the fact that they are not a legal entity, the lack of one big common goal. You have several priorities in that lab, and of course it's very difficult to have everyone thinking in the same direction. How to keep young researchers motivated, the issue of data and data access, so this is really a common denominator in many presentations, the manpower and the slow erosion of preparedness that is seen, I'm sure, not only in Hungary, but in many countries. Oh, there it comes, okay. Vaccine confidence, as one of the last talks. Drivers of the confidence losses, decreased trust, the COVID-19 policies and how that was handled in the different countries, and the misinformation. But key in the whole story is the role of our healthcare providers, because this is the most trusted source for the community, for the patients, for the healthy individuals. They communicate. They can tell a lot about vaccines, about interventions, and they can play a tremendous role to keep the confidence at a certain level. So we need to understand that, and we need, in fact, to be honest, to improve the training of our healthcare providers in terms of vaccination, in terms of communication. So also the emphasis was put on the proactive risk communication and community engagement, having the public much more consulted and much more engaged. And in the communication, the emphasis was also put on, we have to learn to listen. We have been communicating a lot in the COVID-19 period, but how much have we listened to the European citizen, to the European, or to the citizen in the different countries? What do the parents want to hear, and what do the parents want to know? Maybe it's not what we are saying. So we need first to listen, tell the truth in a very respectful way, try to frame it in a positive way. So if we talk about the intervention, let's do that in a positive way. And let's do it also inclusive. We as a community, we as parents, today I would say we as participants of this symposium. And we have to empower individuals to assess the news. Everyone should be able to really assess what they hear on social media, what they read on social media. And we have to start in schools doing that. And there is a very nice initiative from the World Health Organization European region, which is the Immune Patrol, and we work together with them. It's a game for children between 10 and 12 years, and it's about vaccines, it's about infectious disease, it's about herd immunity. But one lesson is about how can I assess the validity of social media. And I think that is very important as well. So take-home messages, I would say, as I said, difference between preparedness and readiness, a call for action to invest in data gathering and data accessibility and data sharing. Clearly a need for structural funding, not only at the level of a country, but in particular at the level of hubs. Need for an immunological lab network in Europe that is well connected. Something we really need to think about is to, and I will immediately show why I put this more performant process in terms of regulatory approval of vaccine and vaccine trials in Europe, but it's not only for vaccine trials, it's about trials in general. This summarizes, and it's a document prepared by the Center for Evaluation of Vaccination of the University of Ghent and our center, is to show how we are losing competitiveness with other continents in Europe, in the world. And this needs to be taken very seriously. We have to find a way, as soon as possible, to fasten this process of approval of studies that are submitted through the centralized system, because otherwise we will no longer be able to play with, I would say, in competition with other continents or other countries closer to us, like UK or Switzerland. Needs for dry run exercises. A question we have to ask ourselves today is, just imagine tomorrow there is an outbreak of avian influenza. What are we going to do? This question we should ask ourselves once every year and do the exercise. What are we going to do at that moment? Who will be the spokesman in the different countries? Who will be the spokesman at EU level? This is something we really need to do, like a fire exercise. Need for more accordance in vaccine recommendation. You know, this is feeding also hesitancy among a lot of people. If I have to take my flu vaccine at the age of 60 in one country, at the age of 50 in another country, at the age of 65 in a third country, this does not help in terms of confidence. So or we have to have more accordance, or we have to explain to the people why there is a difference all over these different borders. We have to survey perceptions among people, the belief among people. We have to survey social media. What is circulating? How can we address what is circulating? Also to invest in confidence and to have proactive activities. And we have to listen. This is so important. And finally, I think this is also a call for action: train the healthcare provider and the future generation of healthcare provider. This is feasible. You just have to change the curriculum. That's a 1-week curriculum in a 6-year educational program for doctors, in a 5-year educational program for pharmacists, in a 3-year educational program for midwives or nurses. This is all doable. It's only 1 week, but it will help to have parents visiting healthcare providers who will receive an answer from an expert. So, thank you very much. And this is something you have to think about. Thank you.
I just decided I'm going to steal your question, and the first question on the panel discussion will be, what if there's an outbreak tomorrow? That's for later. First, we have a fourth report. There was a workshop, founders of clinical trials in Brussels that took place over 2 days. Sharing those findings with us is Professor Herman Goossens, Professor Emeritus, University of Antwerp. The stage is yours.
Thank you very much. Yeah, so thank you very much, and thank you also for inviting me to give me the opportunity to report on the workshop we had in Brussels yesterday and today. And so this was a workshop of the Belgian EU presidency, strengthening the European ecosystem for clinical trial platforms by coordinating public funding. And I think perhaps there was some confusion about this workshop, so therefore I would like to explain first, where does this workshop come from? And I'd like to give a bit of history about the clinical trial platforms and where do we actually come from. And so I want to start in 2016 when I proposed an Australian model of clinical trial networks. What I mean by that is that I proposed at that time to create or to build a single permanent European infrastructure for clinical research on infectious diseases. And that was proposed by combining 2 projects, one on antimicrobial resistance, the Comeback project, and another one on the Pandemic Preparedness and Response project. And that's where the name European Clinical Research Alliance on Infectious Diseases come from. And I want to make a point here, and the point here was that it was not the aim to create a dominant structure but really an alliance. And this was actually also based on or inspired by what Australia has done. And I think you have to understand that we were not the first in Europe to do this. In Australia, they started building clinical trial networks back in 1973. And what they did was to create the ACTA, which is the Australian Clinical Trial Alliance. So a similar concept. But the concept there is that you should have one network per discipline or per disease, and you should not have competing networks. And I'll come back to that. So in 2020, the COVID pandemic hit the world, and the EU and RTD was very fast in funding clinical research, and we received funding to continue the PREPARE studies. So we had started before the pandemic with observational studies, the MERMAID studies, and we started also before the pandemic with adaptive platform trials with response to adaptive randomization. We did this in primary care, the ALICE trial, and in hospital care, the REMAP-CAP trial, and we received funding to continue with the REMAP-CAP trial during the pandemic. And also other projects were funded, other networks were funded, such as EU Response and Vaccelerate, and I call this the EU model, and I'll come back to this. And then the presidency. I am a really big fan of presidencies. I've organized events during the 2001 and 2009 Belgian presidency. I've helped a lot of countries to organize events during the presidencies on antimicrobial resistance. And I'm a really big fan of presidencies because I think it's a fantastic opportunity, particularly for academia, to build a stronger European Union and to have an impact on policy. And so I had the opportunity exactly a year ago to discuss with Minister Frank van den Broek and his cabinet about my frustration during COVID pandemic, and also about the lessons learned, and particularly about the fragmented clinical research response and the lack of coordination with and between the member states. Not because they should be blamed for it, but simply because there was no mechanism for collaboration. And that's something we also published in Lancet Infectious Diseases. So we concluded at that meeting a year ago that the Belgian EU presidency would be a fantastic opportunity to strengthen the European ecosystem for clinical trial platforms by coordinating public funding, and the focus was really on public funding. So this is how it ended up in this visionary document published in December last year, A Europe That Cares, Prepares and Protects, a very catchy, nice title, with the health priorities for Belgian Council presidency. And in that document, there are two priorities on infectious diseases. One priority is about strengthening the EU response to control and to prevent antimicrobial resistance. Now, we had a fantastic workshop last year for 3 days to discuss that. And the other one was another policy area was on strengthening the European ecosystem for public clinical trial platforms by developing the financial means, and also by had discussion on how we could do that. So this was the workshop. We had a meeting yesterday morning, which was a kind of closed meeting with data funders, with all the networks and all the projects, with the COMECT, C4C, Liquid Basic, with Prime, EU Response, Pent and Vaccelerate. And the whole idea was here to see how we could align or harmonize. I hesitate to use harmonize because some people don't like that word harmonize. So that's why I say align/harmonize the different networks. And I think it was the first time that all these networks met, presented their ambition, presented their vision. And I think it was a really, really very good discussion. You know, we have competing networks. That's part of the competitive nature of the calls. But how can we find a way to make sure that they better work together? And then in the afternoon, the minister opened the meeting. Christian Drosnik gave a fantastic talk about the next pandemic and what could cause the next pandemic. I talked about the lessons learned and the way forward. Cornelius talked about the new subgroup for the HERA board and prepares a response. And then we had these discussions about not only clinical trial networks, but also the warm-based networks. And Christian indeed presented the durable network. And we had indeed, as Pierre said, a discussion yesterday about this vaccine and immunology lab. In the afternoon, we presented the preliminary results of the survey, and then we had some very interesting case studies this morning, presented by Belgium, Germany, Nordic countries, and the UK, explaining what did they do, how did they fund clinical research before the pandemic and also during the pandemic, and that was extremely interesting. And then we had a first discussion, only a first discussion, and I'll come back to this. So one of the things I've learned is that if you want to organize something during your presidency, you have to start very early. If you want to have impact and be successful, you need to start early. So after the meeting with the minister, we started working on this in 5 steps. And the first step was to build a database, because we have no data, we have no database. We don't really know who's funding clinical research in Europe. We have some ideas, but we don't really know that. So we started building that database and identified 219 funders in 39 countries. The next step was then to send a survey to these funders to try to understand what did they fund, what were the funding policies, the budget, and the clinical studies that were funded before the pandemic and during the pandemic. So we received 43 surveys from 43 funders from 25 countries, and then the next step was to interview some of these funders to better understand and to get an insight into funding mechanism and challenges during the pandemic, and 16 funders were interviewed from 11 countries. And then we had our first workshop with 19 funders from 12 countries, and also we invited 69 funders from 31 countries to be online. The final step is to have a desktop exercise, and I can tell you already, we won't get there, and I'll come back to that. So, what were the key messages? First of all, there needs to be a shift of mindset from competitive to collaborative mode of funding. That's what the funders were also telling us. You need to have a different mindset. You need to have less competition, but more collaboration. And many of these funders were very enthusiastic to collaborate, but there's no mechanism to do that. The second is we need to strengthen communication about funders. In some countries, the funders don't know from the other funders in their own country what they are funding. And so there's a lack of communication, even within one country, about what they're actually doing. That is a reality. It's also important to gain experience in multinational clinical research based on trustworthy collaboration. This is what we heard very clearly this morning from the Belgian experience and from the Nordic experience. Trust is so important. You have to build trust, and if you don't build trust, you're not going to have that collaboration between the national funders. We also need to diversify the funding mechanisms to adapt to needs and ensure that funding is allocated strategically and, very important, in a timely manner. And then finally, we need to have a clear and transparent decision-making process, align the rapid funding with system responsiveness. It's great to fund clinical research, but if you don't have an infrastructure in place, it's not going to work. You're going to fail with your clinical trial. And then, of course, we need to ensure the quality and the robustness of the funded studies. So what are the next steps? Well, I think we need to develop a new vision. We need to develop an integrated vision of the EU model of building sustainable, warm-based clinical trial networks in Europe. We don't really have that vision for the moment. When we have several clinical networks, some they're doing something, others doing something else, not sufficiently aligned and not sufficiently harmonized. So we need to think about what is actually the model that we want to develop in Europe. Do we want the Australian model? Do we want another model? And do we want something like Australia, the European Clinical Trial Alliance? Or do we want something different? So if you don't have a vision, you don't really know what you should build. So that thing really needs to be done again. And that's what we hope to start doing in the Work Package 5 of Be Ready Plus, that will be led by Björn of the Norwegian Institute of Public Health. We also need to develop an integrated vision of outbreak response mechanism that we developed in PREPARE, for instance, and outbreak response funding. You cannot dissociate those two. They need to be linked with each other. You cannot have a response mechanism without a funding mechanism. So those two needs to be integrated. And that needs to be top-down. You know, in a pandemic situation, you can't have democracy. You need somebody to decide what needs to be done. It needs to be done within days. That's what the UK has done beautifully. They explained this morning. And therefore, it has to be done top-down. You can't have this bottom-up approach. It needs to be done much, much faster. And I think it's very important also to develop a sustainable platform to allow national funds to communicate and address common issues in clinical research funding. In the Nordic experience this morning, they explained that they meet twice per year. And they kept on repeating, that is how to build collaborations. And then, of course, also you need to develop training programs to allow national funders to gain experience in multinational clinical studies and trials. Test, test, test. You need to bring them together, train them, and do all kinds of exercise. So in conclusion, the COVID pandemic is really a wake-up call, and there will be no better time and opportunity than now to overcome fragmentation of health research, such as the fragmentation that we see now in clinical trial networks. And already now, the interest in, let's say, in pandemics is decreasing, and understandably, there are other huge issues in the world now. So, nevertheless, without significant and sustained efforts to build a stronger collaboration between the member states and the EC services, the EU will fail. And the EU will fail and stand accused of having turned its back on the prospect of tackling pandemic infectious diseases to the detriment of the health and well-being of the citizens. And that is our only and major role, and that is to build something stronger for the well-being of our citizens. But there's hope, and the hope is the Pandemic Preparedness Partnership. And that provides indeed a unique opportunity for sustained efforts, but it will only succeed if it's built on trust. Otherwise, I don't think it will work. So finally, I would like to thank Minister Van den Broeke for his continuous fight against pandemics. Already back in 2001, he was very supportive in the workshop, and he's been great in supporting all this. I'd like to thank Gloria Vescabinet and Dirk Kramakers, who's the chairman of the Executive Committee of the Federal Services for Health, Food Chain Safety and Environment, for supporting the workshop. I'd like to thank RTD for funding the workshop through the projects. I'd like to thank the national funders who submitted the survey, agreed to be interviewed, for their enthusiasm, their support, and for their trust, because some of the data are sensitive and some of the funds did not want to share the data. I have to be honest about this, but that's fine. Many colleagues of the participating projects, Be Ready, Equate Base, Vaccelerate, but also the other projects, Carlo here of Penta, because Penta is of course linked to the Alliance, but others who were also present there, Connect, Victoria, and many others who were also present there. And then at last, I'd like to thank the teams in Utrecht for particularly helping with the survey, and then the team in Antwerp, Safia, who's sitting here, David, for their hard work. Just to give you one example, we had to make 265 phone calls to these funders to convince them to submit a survey. And all these phone calls were paid by the research group in Antwerp. They're doing something else than working on pandemics, but that's the way you can get to a good response, and it was not that easy. So, thank you very much.